Top Med Talk.
Nick Majerison here. This piece is taken from the Perioperative Medicine Special Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com. In this panel discussion, you're going to hear Professor Jacqueline Close, Geriatrician, Prince of Wales Hospital, Clinical Director, Falls Balance and Injury Research Centre, and also David Storey, Head of Anaesthesia, Perioperative and Pain Medicine Unit, Melbourne Medical School, University of Melbourne, and the Director of Melbourne Clinical and Transnational Sciences Research Platform. Also, Dr. Doug Campbell, Anaesthesia Specialist at Auckland City Hospital. Have a listen.
All right, opening up to question time, and I think I got my head around how to manage the this electronic part of the questions, and I've had some quite a number of interesting questions that have come in. I'll try and get some of them in order. David, I might start off with you. One of the questions was any subgroup analysis of older and/or frail people in relief.
The short answer is no. I was contemplating this question. I think it's important to point out that that the older and frailer you get, the less likely you are to have elective surgery, and so this was elective surgery. The other point I'd make is, consistent with what I was saying before, that the very strong theme, as Jackie was just saying, has been age and frailty, and that is the patient who you may consider much more, depending on what you decide, but if you assume the patient is for full active treatment, then what you will engage in may be far more interventionist in the intraoperative and perioperative care than would be for a younger patient having the same surgery. So the short answer is no, and I think we need to consider how interventionist we are in higher risk patients, including the older and frailer patients.
And David, again, just in relation to the relief study, another question asks whether there was any mention of pre-op fluid status as a central part of fluid reduction strategies. Non-steroidal use and fluid volumes over the entire hospital admission. So
one of the aims of the relief study, as has been the other studies, is to try and make it as pragmatic as possible, and there were no real constraints on what was done or not done on that front. The Enigma studies and others have been the same. So the short answer is there was no real attempt to control or allow for those, but given that it was 3,000 patients, you would hope that the various approaches to fluids and non-steroidals and things like that were equally allocated due to randomisation, which is the importance of randomising things, that the known knowns, the known unknowns and the unknown unknowns are all randomly allocated to the two groups. Thank you, Donald Rumsfeld. Yeah.
And one question in respect to the your mentioning of rehabilitation tools and websites. Any e-health tools that have been trialled for in the preoperative setting that you're aware of?
Not that I know of, but I would strongly suspect our physiotherapy colleagues have. There is some exploration of using e-health probably in the outpatient setting. Say weight loss clinics and things like that. I don't know of any explicit Prehab tool. If Bernard Rydell is around, he may know of one, but I don't know of one. But I think there is probably a lot of opportunity there. And
finally, the place of goal-directed therapy. Do you think there's again in keeping with the findings in the relief study, do you think there is a place for goal-directed therapy, or we should just go with the prescription approach?
Look, I mean, absolutely. That was what I was suggesting. We need to remember the goal-directed therapy does have a cost, and we need to be, we are very fortunate to work in countries. I was listening to President Trump talk about Obamacare and things, thinking we live in countries with Obamacare on steroids, and I think we're all very grateful for that. But part of the responsibility is to look at value, the quality over the cost, and I think. One of my concerns with things such as goal-directed therapy is just flat out give it to everyone. I would argue that the role of goal-directed therapy is to identify appropriate patients who will benefit from that therapy. As I was saying before, the older and frail. So I think there's a role for both. and I suspect the role for goal-directed therapy will be, as we keep discussing in this, is to identify those who will benefit, and that's who you would target it with. Thank you.
Doug, your turn. Question here is, your access to data is far better than Australia's. So obviously it's one from a very envious Australian. Can you get much closer to real numbers than the Aussies? And do you have a solution of how the Australians could get sort of a similar access to data as you can?
I don't see it being possible in Australia in the short term to access the kind of numbers we can generate from the national minimum data set. So, for example, on my laptop I have 10 years worth of non-cardiac surgical patients with, mortality and days alive out of hospital available to be analysed. You're not going to get that because of the different jurisdictions. So I see the only, for large database research, ask your colleagues to help you out in New Zealand, and hopefully it is generalisable to Australia.
Question with respect to NSQIP. We found that NSQIP tends to overestimate risk. Isn't that better than scoring systems that underestimate risk?
So I'm interested in if that person clearly has local data where they are externally validating NSQIP and finding it is not as well calibrated in their local practice as it is internally validated in the US. So what was the rest of the question?
So the question there is, NSQIP overestimates risk,
yeah.
And isn't it better to have a risk scoring tool that overestimates than one that underestimates?
I think we can get risk tools that accurately estimate risks rather than over or underestimate, but you have to prove it by externally validating it in your population.
Another question is, should I conclude that all non-Australian calibrated risk tools are worthless in the Australian population?
No, they're not. So I think you need to, they are, I think, are they well calibrated is a hypothesis yet to be tested. Can they discriminate between high and low risk patients? I would suggest that any of those that have C statistics of close to 0.9 will translate well to the Australian centres, but what you need is to define a local threshold based on, let's say if we're talking about emergency laparotomy, a local threshold that will define appropriate volumes, say to ICU or HDU or to ward-based care.
Are there studies comparing a doctor's end-of-the-bed impression or estimate of risk compared to that generated by validated risk calculator? And does it vary by specialty or experience?
Those kind of studies have been done many times in the cardiology and oncology literature, and well-validated risk calculators always are superior to the end-of-the-bedogram.
Could also make the comment that the same's been done with frailty. There's an end-of-the-bed frailty study by physicians in New Zealand, and found that there was a lot, there's disagreement between the physicians, and they did not really calibrate well with, I think it was the clinical frailty scale.
If we don't know whether the NELA risk calculator is translatable to the Australian population, should we still be using it for the ANZELA QI? Which risk calculation tool is most generalisable to ANZELA?
I think both Australia and New Zealand don't yet know which risk calculator is going to be appropriate for their setting. So we now have an internally and externally validated risk calculator in New Zealand. I have yet to define its statistical properties in the emergency surgical population. Jennifer Riley will have a Australasian risk calculator available in the next year, I hope. Which of those overseas risk calculators should you use? I think you should be using multiple, and that as soon as you have data available from your laparotomy patients, one of the earliest projects should be to be externally validate based on local data.
Arthur, can I just talk to that for a second?
Yeah.
So there was an ANZELA meeting last night, and this very topic came up. There was a discussion about whether we allow people to choose their favourite calculator. If James is here, I'm happy for him, James Aitken, who's the chair of the committee. But and this is partly a question for Doug, I would argue in the current state it's probably more important that we make an attempt to have a semi-quantitative discussion about the possible outcomes for our patients, particularly in the emergency setting, and what we think we should do, than necessarily, and I think, to use a Churchill quote, the calculators we have are the least worst options. Yes. And I think promoting a quantitative discussion about patient outcome is an important intermediate thing. And as we move down the pathways Doug is talking about to improve the accuracy of what we're doing, it'll become better. But I think the cultural shift is probably the important bit in the short term.
I agree wholeheartedly, and I think also I think you need to separate out the purpose of the risk calculator in this context. In the laparotomy audit, you are trying to triage, so in that circumstance, all of these risk calculators have high C statistics, so they will triage very well in terms of the accuracy.
Arthur James is up the back there.
Thanks, James. Yep.
I'm James Aitken. I'm the chair of Anzela QI. One of the issues that we've discussed in putting this together is trying to keep the data set to a minimum, and all we've asked for at the moment is the final score. If you want the component parts, it increases the size of the data set very substantially, and quite likely the quality will fall off. So it's a bit of a dilemma as to how you balance that out. And if you then say we want to assess different calculators that need different data points, you push up the amount of recording even further.
Yes. Well, as I said in my talk, I describe myself as a lumper. Yeah. So I don't want large number of data points. You can do this very well with low number of data points. And in the NELA paper that's just been published with its risk calculator, the best risk calculator after the NELA risk calculator was the SORT, Surgical Outcome Risk Tool, with 6 covariates. The NZ risk uses those 6 covariates plus 2 others and will be applicable to a New Zealand setting. And I think Jennifer is going along a very similar route. So I don't think you need you don't need 22 covariate risk calculators to do what you want to do.
I certainly think it's something that we should explore further.
Thank you. Jackie, there was a lot of interest in your talk. Why don't we routinely measure absolute time from the fracture and or admission to fracture fixation, should we?
We should, but we can't. So there is no mechanism for recording time of injury, unfortunately. So people get brought to hospital following the fall, but there's no documentation of the time of their actual injury. Some people are on the floor for 2 or 3 days. Some people are picked up within 30 minutes. There is no documentation in our current administrative data sets that tell us the point of injury. So we can't, unfortunately. I'm not saying it's not important. So we do the next best thing, the time that they present initially to hospital. And we also do very definitely include transfer times. So the last thing we want to see is gaming of the system in terms of manipulating your time to surgery. So there are hospitals that take in a lot of patients from other hospitals. Your time to surgery starts from the point of presentation to the initial hospital, not the operating hospital. And there are clearly some hospitals that do this very well, and there are some hospitals that clearly struggle with the transfers. But what we don't want to see are people being left in the non-operating hospitals so that you transfer them on the day of surgery, so you make your time to surgery look wonderful if you're only looking at the operating hospitals. So we're very careful about making sure we look at that length of time.
And Jackie, can you recommend a 1-minute tool to screen for pre-op cognitive impairment applicable to the clinical and ward settings?
So I use the 4AT, which includes screening for delirium, but within the 4AT is the AMT4, so that's the abbreviated mental test 4. So 10 questions was too many for most people. So we're down to 4, which is age and date of birth, year and place. It is a really, really brief cognitive screen.
And in your study, who did the frailty screening and referral to the shared care geriatric service?
So Christina is sitting down there. Christina was the fellow for the period of time that was running. In fact, it is still running, so we've had funding to keep it going. Christina did the screening. The surgeons actually chose the tool for the screening. So again, the surgeons preferred the pictures. And on the whole, the surgeons seem to be, as Doug calls them, lumpers. So the surgeons do not want big, fancy frailty tools with 20 or 30 different variables. So most people relate to the clinical frailty scale very easily. Most of us feel comfortable with it, and it was Christina. But the CNC in surgery also was able to use it. And in fact, the surgeons get it. They know now who to refer.
Given the improved outcomes of COPS, which was in the acute surgery, is the next step to do pre-admission clinics with at-risk older patients?
Yes, almost certainly. But just because something's successful doesn't mean to say that it is necessarily funded. And so we're still going through the battle of getting it funded. So Michael told us the other day that Nepean have now got their model of care funded long term. We're still with the business case with Prince of Wales getting it funded. It's still running. Yes, the next step is potentially to go down the elective route. We will probably use frailty as the identifier for the population that we want to see. And we very definitely do not want to be setting up something separate to perioperative medicine. So it's working out how do we work with the perioperative medicine space to work out which patients we see and how we work together. So that is potentially the next step.
Just to show you, I'm still a bit of an old-fashioned chair. I'll take a question from the audience.
Sorry, I take exception to that. We don't know when the fractured neck femurs occur. Having anaesthetised these patients for 30 years, I still do, I doubt would have ever come across somebody who couldn't time the fracture within a couple of hours. The vast majority you would know within the hour when it happened, and even the most demented, probably poorly rated nursing homes, you'd know within several hours. We know that we've had hospital transfers from hospital to hospital to hospital, and know the time from when they had the fracture to when they arrived in theatre, and that's almost universal.
I'm going to choose to disagree.
And one last question. Anybody?
Sorry.
Yeah, go.
I'll just go on for Jackie. I'd make the point there. I think one of the issues is we as clinicians can pick this up, but whether it's adequately recorded in notes, I think that's probably more the difference.
It isn't.
Is that I entirely agree that if you quiz the family and quiz everyone else, you can often get a time. But whether that's actually adequately recorded for research and audit purposes, I think is probably the bigger issue.
There's no variable in the administrative data sets that tell us for time of injury.
I disagree with you. I mean, I agree it could be, and I agree it's easy to find, but whether if you went to 100 histories at your hospital and Doug could find it 100 times out of 100, I personally would doubt it, but I'm not saying you're wrong. I'm just saying. All I can say is wherever you work, you're bloody lucky.
Yeah, I was about to say that as well.
Just one point about the clinical frailty scale, just to confirm, Jackie, my understanding is that there's evidence to support it's valid for non-geriatricians to use it appropriately as a screening tool.
So it certainly has been used in non-geriatrician populations.
Because I understand the intensive care group are now looking at doing it routinely in intensive care patients, and there's evidence that both the research nurses from Sean Bagshaw, I think in Canada, showed that both research nurses and junior ICU doctors can adequately use the tool. So I think that's a particularly important point in using that particular tool.
All right, thank you, everybody. Look, I'd like to draw the session to a close. Can you please thank the speakers?
Nate Geriatrician here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of APPMU, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. APPMU.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.